Good morning, Baus. My name is Seth, and I'm a urologist from St George's Hospital in London. And thank you for allowing me to host on the much-awaited female urodynamic and urology Baus poster session. This is EPoster session 3, and I'll do the first few posters and then hand you over to my colleague, Mr. Belal, who will go from poster 8. So moving on to the first poster. This is a look at the bladder management of almost 50 patients with spina bifida. And again, when you go through the study, it really stresses the importance of the bladder management and assessment in this group at a very early age, and the importance of proactive management. We know a significant proportion of these patients can go on to have urological complications. And in this particular study, video urodynamics showed neuropathic bladder features in the vast majority of patients, and DMSA scanning showed scarring in up to 20% of patients at a really early age. So again, it stresses the importance of protecting the upper tract and the need for a clear self-catheterization regime established from an early age. And again, it also goes on to remind us that these patients need long-term continuation of care through childhood, adolescenthood, and then into adulthood. So thank you for that. If we move on to the next poster. So poster 2, this is moving on to look at a large number of Indian patients with spinal cord injury. And there's 1,200 patients, all having self-catheterization, of which 2/3 is done by a carer. And it was an incredible discovery here that 51% of these patients developed occult or symptomatic urethral strictures, which is a very high rate to be reported. And again, a range of stricture locations was described from the penile urethra to the bulbar urethra or panurethral strictures, of which 25% of patients needed endoscopic management. So again, it's a reminder to all of us who are managing these patients, the neuropathic patients, and carrying out the bladder management, that there is a high incidence of urethral stricture. And these patients may not be aware of it necessarily. They may have altered sensations from umbilicus downwards or various loss of sensation. And so they may themselves be less likely to report it, and especially if catheterization is carer-led. So again, it's important to be aware of this, and there's also potential role here moving forwards for study into different catheter types, perhaps different lubricants to minimize the incidence of this, but clearly a very important entity. So thank you again. And moving on to poster 3. So this is a meta-analysis looking at the use of antimuscarinics and the potential cognitive effects. This is incredibly topical, this subject, and within this meta-analysis, there's 6 randomized controlled trials that have been included, encompassing 2,500 patients. And there's a slight suggestion that darafenacin may have more cognitive side effects than trospium, although that's not a strong effect. And oxybutynin, there's no significant difference between the immediate release or extended release forms. Again, this is clearly an area which needs more study, but it's a subject area that's very difficult to examine, really, because there's so many variables, including that of other medications that patients may be taking and other medical conditions which may affect their cognition. So it's great to see some information coming out in this, particularly because this patient cohort has a high incidence of overactive bladder. And managing the overactive bladder in this group may be challenging, because a lot of these patients may not be able to have botox and therefore unable to self-catheterize. So it clearly would be an asset if we knew who we could treat with antimuscarinics safely. So congratulations, well done. So moving on to poster 4. So this is a look at self-catheterization rates after, or retention rates after treatment with Botox. And again, because of the growing population of Botox patients that we will all be seeing in our continence services, this is one of the main drawbacks of Botox. And so this is a large patient population, over 400 patients, of which 25% were men, and also a significant proportion had previous pelvic surgery, about 50%. And it was interesting to see that self-catheterization was reported more in incontinent women with detrusor overactivity, and that women with voiding contractions were more likely to have a positive result. We do need more study into this area because, as we've mentioned, this population of patients is growing, and we are applying Botox to patient groups outside of the initial studies, large volume phase 3 studies, where Botox was shown to be efficacious in spinal cord injury, multiple sclerosis, and idiopathic overactive bladder. But we are applying this to other patient groups, including perhaps men with BPH or overactive bladder, or other groups, including bladder pain. So self-catheterization is an important thing to be able to counsel patients on. And so that's very valuable. Thank you. Moving forward. So poster 5 and 6 we'll consider together because they come from the same group. And it's a delve into some basic science, and it's exciting to see some basic science enter the BAUS FNUU arena. And we're turning now to the subject of bladder pain syndrome or interstitial cystitis. And again, a very challenging area to assess and manage because of the limited treatment option that we have in this group. So this is a deep dive into the pathophysiology of this condition, and substance P has been nominated here as a key player in the pain signaling, neurosignaling of bladder pain, and its action through mast cell degranulation. And this was shown in the vast majority of bladder biopsy specimens. And it also poses the concept of Manuka honey as having a place in switching off these pain pathways, and whether Manuka honey, through its anti-inflammatory role, could have a treatment role within this field. And there were some promising results in vitro of Manuka honey switching off the signaling. So again, it's very exciting to see this, and the mind goes on to think whether this moving forwards would be translated into topical therapy with intravesical installation or systemic therapy, or whether it would be introduced into the diet, and maybe looking at patients who have a high volume of honey in their diet and whether they have any changes in their bladder. And then also further wider scale applications into whether this could help with the overactive bladder or even the patient with recurrent UTIs. But again, it always starts with the basic science and then translates from there. So congratulations on this work, and thank you for that. So, and if we move on to number 7. Right, so now this is sticking with the theme of bladder pain syndrome or interstitial cystitis, and is looking at the role of Botox in the management of these patients. And again, it's a very topical area, and an area that has been met with a bit of cynicism in the past, where some reports have suggested that Botox has been of use and others have suggested it hasn't. But it's great to hear some positive results of the use of Botox in this group of patients, because again, these patients in reality do have limited effective treatment options. There's clearly a lot of work to be done, but this is a systematic review looking at 9 randomized controlled trials where there's been positive results of Botox against placebo, against pentosan polysulfate, against hydrodistension, which are some other forms of managing this. And again, there's a lot more study that needs to be done, really looking at the different doses and the durability of Botox, and potentially looking further into the different phenotypes of bladder pain syndrome. But it's great to see some positive results in this arena. So again, thank you very much for this. Brilliant. So I'm also going to be looking at poster 12 as an add-on, and this is a look at the Metronome site, whether umbilicus or iliac fossa is preferential. And so this is a very large group of Metronome formations in adults, almost 200 patients. And where would you cite your Metronome? Well, this fascinating retrospective look at a large volume of patients has shown us that there is a slightly higher skin revision rate for patients with Metronome cited in the right iliac fossa, with a 55% skin revision rate in the umbilicus and 75% skin revisions in the right iliac fossa. Continence and usage of the channel was equal across both sites, and the average follow-up of this patient group was over 4 years. So clearly it may influence where you put your next Metronome, and so do bear that in mind. So again, thank you very much, and congratulations to all of the teams and posters producing work, and for your contributions and knowledge, adding to the knowledge base for BAUS FNUU, and I hope to see you all face to face soon. Thank you.
Good morning. My name is Belal. I'm a consultant urological surgeon from Birmingham. I'll be doing an update on poster 3, starting from poster 8 to 15. The first poster we're going to discuss is the use of Botox injections in patients with augmentation cystoplasty. This cohort of patients with augmentation cystoplasty, a small proportion of those will have a negative result. And in this study, examining 30 patients, they examined the outcome of Botox injections. What they found is that, in fact, higher peak diffusive activity pressures appeared to be significant in terms of the benefit from the Botox injections. They roughly divided their patients into idiopathic diffusive activity and neuropathic diffusive activity, with slightly a greater proportion of the idiopaths. This demonstrated that the patients had a good outcome in approximately 43% of the patients, which is a very good result considering the other alternative is further significant operations. So I think for the small cohort of patients who don't necessarily have a positive outcome, then Botox injections is effective. Be interested to know what particular dose they use. They used between 200 to 300 units of Botox, though some people they did begin with 100 units. So the next poster we're going to discuss is voiding dysfunction in men, and they've examined a cohort of patients which they've looked at. I must admit, men tend to be a smaller proportion of patients with secondary modulation, especially in terms of voiding dysfunction, and they've looked retrospectively at approximately almost 37 patients at the median age of approximately 48. They also examined the etiology of the cause of the voiding dysfunction, and determined whether or not they were just simply diffusive failure or whether they had a high pressure non-relaxing tone. And what they examined was whether there was a significant success or not. I think what they found was for the patients who had a successful outcome, the overall successful outcome was probably approximately 40%. But once they had a successful outcome, then that was durable. So it certainly gives us an idea that it's worth testing men with voiding dysfunction to see whether or not they have a positive outcome, either on a PE test or a time lead test. And if they do, then it's certainly worthwhile planting those. In addition, it does suggest that the underlying cause of the voiding dysfunction perhaps is not as important and is not predictive of success. The next poster we're going to look at is it's the durability and the presence of complications of ileal versus neobladder unidiversion post-cystectomy. And so what they've done here is they've performed a systematic review, and they've gone to the standard literature and then found a number of articles which were acceptable. And what they've looked at is several parameters, including post-op mortality, which they felt that there's a slightly higher post-op mortality with ileal conduits versus neobladders. They also looked at complications, and so in the Clindal Dindo system, they looked at minor complications, which the ileal conduit was less than neobladder, but that was not clinically significant, or with the p-value of 0.21. In addition, they examined major complications, which they found an ileal conduit to be greater than the neobladder. Interestingly, they also found that mortality was higher with the ileal conduit of 9.6 compared to the neobladder of 1.6%. I think one of the problems really is the patients you select for ileal conduits tend to be different than the patients for neobladder, and I suspect a lot of what they are showing is perhaps the factors of why you'd use an ileal conduit over a neobladder. And certainly there are patient factors which are really important, which means that patients are not suitable for neobladders. So perhaps this meta-analysis is perhaps not indicative that this is a significant issue in terms of mortality as well as complications. And again, I think there may well be a significant selection bias, but nevertheless, it does certainly add to the idea that perhaps orthotopic neobladder doesn't have a significant risk of increased morbidity. The next poster we're going to examine is the fate of the remnant bladder in terms of an ileal conduit for benign conditions. And certainly, again, a retrospective study, but with a significant number of patients, with over 100 patients, and the median age is 52. So this has always been a perennial question in benign disease, whether or not you leave the bladder in situ, or whether you take the bladder away. Obviously, the advantage of taking the bladder is that it's one operation, it's done. The disadvantage is it does add morbidity to the procedure. And so certainly it's something to be considered carefully. And so what they actually found is that a significant portion of the patients actually developed a complication with approximately 44%. But the median follow-up was only 44 months, which is, perhaps is not long enough to know for sure what the ultimate outcome would be in all the significant patients. Certainly a significant portion of the patients with the painful bladder had to have it removed. I must admit, in my practice, we tend to remove the bladder in patients with painful bladder, and they had a significant portion of patients with mixed urinary incontinence. More interestingly, I think they certainly found one patient who had developed bladder cancer and required a radical cystectomy, and a quarter of the patients also required a further cystectomy. So I think I'm not necessarily agree with the conclusion that routine simple cystectomy is not required, because I think it has to be an informed decision, and certainly with the data being presented, and if you explain to the patient there's a small chance of TCC developing the remnant bladder, I suspect there would be a higher uptake in terms of removing the bladder. But nevertheless, a very helpful study to know what to do in this group of patients. The next poster looks at Metronome and whether or not the Metronome is better when made in the bladder or in adults or in the neobladder. So again, I think they looked at a multi-surgeon center with at least 9 surgeons performing reconstructive surgery. They examined where they actually inserted the Metronome channel. And most people would normally perhaps do it within the native bladder, and they examined when they do it within the near bladder and also the clam segment. And what they found really was that, interestingly so, that the majority of patients with the near bladder were induced at the last follow-up, and it appears that there's slightly less people using in the native bladder, and the clam segment was perhaps in between. So I think, just show that perhaps that if you perform it into the clam or the near bladder, you tend to have a better outcome. But I suspect there may well be some significant bias, particularly examining what age this was performed, because generally speaking, if you've performed surgery as a child, the outcomes tend to be better. So I noticed that it's difficult to untangle this, but nevertheless, it does perhaps show that maybe it's not as bad as when the Metronome within the bowel segment as it is within the native bladder. So this is a very interesting study, which is looking at the robotic-assisted bladder diametectomy. And certainly, I think this examined patients who've had this removed over a period of 5 years. The average median age was 61, and they've performed a follow-up of 24 months. The mean operative time was approximately 3 hours with pretty much minimum blood loss. And in terms of complications, there's only one really significant complication with the hematoma evacuation. But in terms of their outcomes, the patients tend to have a very positive outcome. So I think perhaps this showed the paradigm shift within the benign and functional field, that the robot's here to stay, and certainly is an alternative to open surgery. And I think it certainly does open the doors towards the idea that certainly in the future, robotic assisted surgery will be the platform for performing a lot of the surgery. In particular, in terms of primary surgery, I suspect the robotic platform is perhaps not ideal for redo surgery, but certainly, it'll lend itself to procedures such as corporal suspension, artificial sphincters, bladder neck artificial sphincters, a primary clamp perhaps in the future. So I think we will certainly watch the space as things progress. So the next poster. So this is a very interesting poster examining bladder overdistension and the long-term functional outcomes. And I think this is certainly what we all have, patients who've had an overdistension injury and then subsequently have had significant issues. So in this series here, you have approximately 18 patients, and all of these were derived from a medical malpractice within the UK, and predominantly, not surprisingly, 17 of those patients out of the 18 were female, and the median age was 31. And it would appear that a lot of the preceding invented surgeries were gynecological, with certainly 11 of those vaginal deliveries. And it does appear to be that's a single factor associated with this. In terms of their retention volume, it's very significant, with almost 1.5 liters, and it certainly had it for at least a significant number of hours. And the question really was, what was the outcome? And it would appear that a significant proportion of those patients were able to abort spontaneously, which is approximately 50%, but certainly the other 50% were pretty much dependent on self-catheterization, though a proportion of those may be able to self-catheterize. So I think it's an important study to counsel patients who've had an overdistension injury that they have approximately a 50% chance of avoiding spontaneously. And certainly it also shows that once you have an overdistension injury, that if you do head towards medical malpractice, then you're likely to win as well. Thank you very much.